In this video, we'll be going through the topic recurrent overt obscure gastrointestinal bleeding in a cirrhotic patient with history of Roux-en-Y gastric bypass. Our patient is a 57-year-old male with a history of baseline compensated alcohol-associated liver cirrhosis with a Roux-en-Y gastric bypass 11 years ago. He presents with melena with an initial HB of 7.5 with gastroscopy finding grade 1 esophageal varices. Extensive endoscopic investigations were performed due to persistent melena, and a computed tomography of mesenteric angiogram did not show any significant active bleeding but found gastric varices. Here you can see prominent gastric varices noted in the CT. Here you can see the balloon enteroscopy that was performed. Towards the left, we have the afferent limb with a blind ending into the stomach. At a certain point in the small bowel, you can start to see evidence of previous episodes of bleeding. And a lab gastrostomy and on-table gastroscopy was performed, this time showing us the cause of the bleed. On the left, you can see the nodular liver, and on the right, you can see prominent splenic varices. As we make an incision to the stomach, we can see the blood is gushing out, with significant clots seen on entry to the stomach. After draining the blood in the stomach, we identify the area of bleed, which is a spurting fundovarix noted in this image. The bleeding spontaneously stopped in this video. Here we attempt glue injection of the varix. However, the bleeding continued despite glue injection. As you can see from this video that the angle of the location of the varix is rather challenging for further endoscopic therapy, and so decision was made for direct suture ligation. Hemostasis was achieved after direct suture ligation, as you can see here. This case provides insights into the diagnosis and management of GI bleeding in patients post-Roux-en-Y gastric bypass. The evaluation of overt obscure GI bleeding is challenging, further heightened by those with altered anatomy. Variceal bleed from the excluded stomach needs to be considered, and thus collaboration between gastroenterologists and surgeons is essential to evaluate these patients.